This is Stephen Holloway. This is Nursing 203. We're continuing our discussions on congenital heart defects. Our next defect is called pulmonary stenosis. Now, pulmonary stenosis is one of the defects with decreased pulmonary blood flow. The incidence of pulmonary stenosis is about 8 to 10% of all congenital heart defects. When we look at the pathophysiology of pulmonary stenosis, there's a narrowing of the pulmonary valve with obstruction of blood flow from the right ventricle going to the lungs. Now, this narrowing can be what they call valvular. It can be supravalvular or subvalvular. And I have a graphic, and we'll talk about that a little bit more in a moment. But what we see is the right ventricle cannot pump the blood out or pump out decreased amounts of blood into the pulmonary artery. Because it's pumping against greater force to try to get that blood out, many times we'll see right ventricular hypertrophy, and it can eventually lead to right ventricular heart failure. Remember when we looked at our signs of right ventricular heart failure, what do we see? We see buildup of fluid back in the systemic circulation because the fluid coming into the right ventricle is coming from the systemic circulation and being pumped out to the lungs. So eventually we're going to see those signs and symptoms of right-sided heart failure. Now, we talked about there are basically three different types of pulmonary stenosis as we look at it. There's valve stenosis, where there's actually something going on with the valves itself. It may be that the leaflets of the valve are fused together. They may be hard and rigid. They may not open and close properly. So that's basically just for some reason they're oversized and it's too narrow to get through there. Then there is basically the subvalve stenosis. There's some overgrowth of maybe the ventricular septum or the septum here between the atrium here. And what we have is a narrowed path here so that as the blood is trying to be pumped out of the right ventricle, it's having to go past that stenotic area to try to get through there. So again, can lead to the same type problems with the right ventricular hypertrophy. Then we can have supravalve stenosis, supra meaning above the valve. So we have a normal pathway here, but as we see, there's a constriction of the pulmonary artery here as it tries to go out. So there's a stricture here. Again, creates the same problem in that the right ventricle is having to work harder to move the blood out to get to the lungs to be oxygenated. The degree of pulmonary stenosis is determined, basically how they determine how much stenosis is by measuring the right ventricular systolic pressures at rest. A mild stenosis, there's a low pressure. A moderate stenosis, the right ventricular pressure is equal to the left ventricular pressure. And severe stenosis is where the right ventricular pressure is greater than the left ventricular pressures. Again, this will all, as the stenosis is worse, it will cause more symptoms, especially if we're looking at that severe type process. All that this means that basically there's a decreased amount of blood flow to the lungs. At rest, the body can compensate. In the infant, with feedings or crying or exercise, there can be problems. In older children, they may not be able to compensate and develop and may have intolerance. There may be some cyanosis with these children. Children typically with mild to moderate, though, are asymptomatic. It's when it gets into that severe pulmonary stenosis that we see the signs and symptoms of dyspnea on exertion. The child fatigues easily with cyanosis. That kind of goes into the slide here. Well, I'm sorry, I got a little ahead of myself. But as we look at these clinical manifestations, again, we're looking mild to moderate asymptomatic. Severe, we can see those problems. These children typically will have a murmur. And remember, because this is the pulmonic valve, we're to listen for that valve that you should know from 103. Go back and review that if you don't. It's going to be a systolic type murmur that you're going to hear. Many times you're going to have a grade 4 to 5 murmur on these children, and it may radiate up to the suprasternal notch. There is sometimes in these severe type cases you may be able to feel a thrill, and that may be in the upper left sternum area. You may also have a split second heart sound related to the late closure of the pulmonary valve. When we look at these and we're trying to diagnose these, most of the time it's noticed because of the signs and symptoms, the clinical manifestations, and then hearing the murmur. Once we do that, we begin the workup. Of course, we're going to look at a chest x-ray, and what we can see, we can't see the stenosis on a chest x-ray, but what we might see is that right ventricular hypertrophy, or we may see cardiomegaly because of that. We may see those on the chest x-ray. An echo will tell us basically the size and the function and anatomy of the pulmonary valve, though that's kind of the standard that we're going to do, non-invasive. We can also do a cardiac cath to actually look at the size of the valve and discuss and see what can be done, and that will also give us a good idea of where the stenosis is located. Is it below the valve? Is it at the valve? Or is it above the valve? As we do those cardiac catheterization type processes. Again, we talked about the manifestations. Those, I must have hit the wrong button there. Treatment. In our premature infant, or in our newborns and our premature infants, because of the stenosis, we want to keep that PDA open. We'll allow that blood flow to go through that PDA and go through there. That basically keeps blood flow going to the lungs. We will actually give these children prostaglandins to keep that open. Remember, the prostaglandins are the drug that's responsible for keeping that ductus arteriosus open. So this really shouldn't say PDA. It really should just say the ductus arteriosus. But what we're trying to do is prevent that from closing, and we want to keep it patent as we get through that whole process. We want to keep that ductus arteriosus open. Depending on what's going on and where the blockage is, where the stenosis is, if it's within the valve itself, we can actually do a balloon valvoplasty, where actually it's done through a cardiac catheterization. It goes up and the balloon is blown up to kind of break open that valve. Can you create more problems with that? Absolutely, but it is a least invasive of trying to do those type issues. Now, if the stenosis is in other areas, if it's supra and it's the vessel, again, we'll try the balloon type area and maybe put in a stent to help hold it open for those. If it's extra material that we looked at with the substenotic type processes, typically these patients are going to have to go in for surgery and have that area removed. There are some ways to actually use alcohol and actually kill off some of that tissue, but that's, again, these children, it's going to depend on how severe the stenosis is. The majority of the pulmonary stenosis actually is at the valve level, so that's where you're going to see most of your problems with these children. What are the complications that go along with this? Ventricular arrhythmias can occur. We can development of pulmonary valve insufficiency with the balloon if we blow it up too much and do that. So we created another problem. But at least we've got good blood flow going through there. We're just going to get some regurgitation if we do that. These children may always have a murmur even after we do the balloon valvoplasty or we do the surgery. Even if these children have mild stenosis, we're going to see them on a routine basis because that stenosis could get worse. So we're watching them for signs and symptoms of heart failure, worsening of the murmur, worsening of that flow. So they're going to be followed up with routine echoes during their history or during their childhood. So basically, once we look at pulmonary stenosis, there is really no mixing of the blood. This was not one of those right to left shunts type processes that we typically see with these outflow type problems. There's really some damage or some problem with the valve, above the valve or below the valve, preventing the blood from getting out of the right ventricle into the lungs. Overall, long-term problems can be congestive heart failure, right-sided heart failure. But the goal is to open that valve and allow the blood flow to go through. All right, that concludes pulmonary stenosis. We'll be moving on to the next topic in just a few moments, tetralogy of Fallot. Thank you.